And all my patients are referred to the ID and chest specialists. So that's a disclaimer, chiefly because it's very difficult to deal with so much of knowledge for starters. And the other thing is complications and side effects and changes in dose and all. So it's much easier at my level of practice to refer, and we still have questions. Anyway, so I'm going to try and get through this only for spine. So there's this 22-year-old female who had pain, constitutional symptoms, some weakness in the legs, not too much, difficulty in walking, needs support, and this is her MRI. And for those who are not used to seeing MRIs very much, there's vertebral destruction, prevertebral abscess, intraspinal abscesses, and cord compression. Now, this is something which one would immediately start planning, which theatre, what time, who's the anesthetist, and which implant to call. And but what was eventually done for this was AKT. So of course biopsy, yes. Without biopsy, never. So biopsy, AKT, and you can see in 3 months, you can see the difference in the MRI. And by 9 months, it was completely healed. And therefore, the message I want to give to you, and it's not with this case, but this message, there are only 3 slides of mine which are important. And this is the slide. That spinal TB today is essentially a medical disease. It is to be treated medically, and surgery is only reserved for its complications and sequelae. So we have loads and loads of TB spine even today, but the amount of surgery has gone down to, I don't know, maybe less than 1 a month. Whereas I remember in our KEM days, we were just flooded with TB spines who we used to operate. So let's see what is the role of surgery. Let's try to put this in perspective, because the truth is not that no patient needs surgery, and definitely the truth is not that all patients need surgery. And my dear friend Gautam, who's going to probably punch me in the break, but he said that stability is required for AKT to act, and I'm sorry, no. All I can say is no. Okay. Anyway, so medical management alone is highly effective in treating spinal TB, irrespective of what the MRI looks like. So that's also very important. Clinical grounds are different, but if you only look at the MRI, because I have seen, in the earlier days when I started conserving all of these, and I had other people, especially neurosurgeons, they would say, oh, lot of destruction, lot of abscess, but it doesn't matter. It doesn't matter what the MRI shows. Surgery is the exception rather than the rule. And whether you have something like this, where you can see abscess, you can see cord compression, but clinically, so I'm saying if this same patient has grade 1 or 2 power, we need not, I'm not going to say we're going to conserve this patient, but if this patient is walking normally and just has a little back pain, there is no need to operate him only based on the MRI. And we used to do follow-up MRIs for these patients, and we can see complete healing in these patients. Even something like this with a very large abscess, stiffness, dysphagia, and like I said, start planning the theatre, C4 to C7 corpectomy, plate, anterior, posterior, all of that. If you look at this MRI, scary, massive abscesses. Even the abscess was not drained. Just AKT in 4 months, this is what the MRI looks like. So the point is that AKT is highly effective, irrespective of what the MRI looks like. Your decision is based on clinical grounds. And what we tend to follow, of course, is what is called as a mid-path regimen, which is medications, rest, maybe bracing. Most important thing is review and monitoring the patient, and then surgery for the specific indications. So yes, surgery is necessary. I mean, we wouldn't be here if that wasn't so, because if AKT is so effective, then why operate at all? I did say we do once a month. So surgery is not for the disease. It is for the effects of the disease. It is what the disease causes. And the effect of the disease may be on neurology, which to us as spine surgeons is the single most important thing, but also on the structure of the spine, which in the short term may be pain and instability, and in the long term would be deformity. So honestly, this is all that we are looking at. So what are the indications for intervention? And this actually is way back in the 50s by Seddon and Butler. And there would be these 4 indications for surgery: neurology, the disease, deformity, and debilitation. So these are the 4 indications. In slightly larger detail, If there is a dense deficit, like I said, if the patient has come with grade 1 or 2 PAR, not able to walk, we can still conserve. There are people who would even do that, but not me. I think in the modern era, we would operate these patients. If the patient gets worse on treatment, again, you would review the whole case, but likely to go in for surgery. Deficits not responding. Disease, I'm going to come to this in detail as to when there is no response or continued pain, what is to be done. But diagnosis in doubt sometimes. I mean, of course, yes, biopsy, but sometimes need surgery. Deformity, yes, childhood TB, there are specific indications. I'm not going to cover them here. You need to read Rajshekharan's paper. But prevention of deformity in children, very important. If there is really extensive many segmental circumferential destruction or a progressive deformity, we as surgeons are able to treat that. Debilitation is another thing which we do sometimes. If a patient is really bedridden, an elderly patient is bedridden and he's just going to be in pain, then we can do some kind of minimally invasive stabilization and mobilize this patient. It doesn't, like I said, it's not to cure him from the TB, but it is just to mobilize the patient. So let's look at why neurology becomes an indication. So the causes of neurological deficit is important. It either may be compressive or non-compressive, but in the large majority of our cases, it's compressive. The non-compressive can be vascular, which is a little questionable, or a meningeal or a meningitis. Compression, I think of it as soft compression, which may be an abscess under pressure, inflammatory exudates, and granulation tissue. So these are the soft compressions. And then there is also hard compression. So there are sequestrae of disc and bone. There is an internal gibbous if there is a deformity, and there is an actual translation, which is a hard compression. So you need to be able to differentiate these two for the simple reason that they behave differently to therapy. So abscesses such as this, which are under pressure, this is like a carpet of granulation tissue. And if you operate a TB spine, you would have seen all of these. Or sequestrae. And in fact, when I used to, we used to operate many more, we find that those with severe neurological deficit are those who have these sequestrae of bone and disc compressing the cord. This is an actual internal gibbous, which is causing the cord compression, or an actual translation which is causing the neurological deficit. So now if you have abscess or granulation tissue, this is amenable to medical treatment, and therefore you can give a conservative trial. But if you have sequestrae, an actual gibbous or a translation, it would be too much to expect that AKT is going to get this better. So I'm just trying to give you the mid path. Like when I say don't operate, doesn't mean don't operate everybody. If somebody's got a deficit who's got a bony compression, then you do need to operate. And these patients, you can't do a conservative trial, you need to operate. So therefore, if a patient comes with neurological deficit, which is dense and he cannot stand, it is much better to go in for surgery because you give him the benefit of early neurological recovery. Yes, it can be argued you put him in bed and give him AKT and he may get better eventually. But I think the quality of recovery and the guarantee of recovery is better if a well-executed surgery is done for such a patient. Patients with milder deficits, you can treat conservatively. And if they don't recover again, you can go. There's no rush like to go in for surgery. You can start them. Or if they have worsening, then they need to go for surgery. What about the second indication, which is disease? So that is a little modified. In the older one, patients whose disease was not recovering went for surgery, but that is not necessarily so today. So if the clinical response is poor, there's continued pain, the MRI is not improving, which I'm going to have a slide about that later as well. And the markers are not getting better, like weight gain, ESR, etc. You can say that this is poor response. And this can be for a variety of reasons. One of them can be resistant disease. And when I say resistant, I've put into inverted commas because that would have a whole bunch of other things. It is not just that the disease is resistant, but it also could be that the patient is immune compromised, or as we pointed out, as was pointed in the previous thing, the drug dosing is not proper, absorption is not proper, spurious drugs. So there can be a whole bunch of stuff under the thing of, what I mean to say is the drugs are not working on the disease. When I say resistant disease, there can be mechanical factors which are including the pain, which is instability. Or in fact, there can be a mistaken diagnosis that you're treating this with AKT, but it is something else. And therefore, the algorithm today would be, if there's a poor response, the most important thing is to sit down and review the case right from the beginning. Don't just keep on going from OPD to OPD saying known case of TB spine and then just go on treating it. Just go back. Like, have you done everything for the diagnosis? Have you done a biopsy? What was the actual result? Or did you just pick one thing on that and treat it? Did you just look at the histopath where it said granuloma and then start AKT, or was something else positive as well? And discuss with your colleagues in microbiology as well as in ID. And also then study the structural aspects of the spine. See, so what we do a dynamic X-ray. We'll do one lying down, one sitting up. If there's collapse, if there's that could be the cause of pain. And if it's instability, you treat it on merit. And when I say treat it on merit, I am again not saying you have to operate all of them. One word about instability in TB spine. There is a difference. There are different types of instability in the spine. There are those which are temporary instabilities. So if you have an instability in TB spine on day 1, but you give AKT, it's going to heal up and it's not going to be permanently unstable. So it's even instability is not a hard indication for doing surgery all the time. But if you're giving AKT, patient is not getting better and the spine is unstable, then yes, you need to do surgery. And the other factors, if the late responder, resistant, etc., then you need to have a look. You may need to do a repeat biopsy. You need to again involve your colleagues in to see whether blood levels are proper, absorption. Is he actually taking the drugs properly? Is he taking some other drug which is causing the... So all of that we cannot do. So let the medical experts handle that. And after that, then do they need debridement or not is a little tricky question. If you find a surgeon-friendly ID guy, they may say, please do a debridement, and then you happily go ahead and do it. But it just tweaking of the drugs may just solve the problem. One slide about the MRI. So an MRI, I think the most important thing to know about an MRI is that for TB, it takes 3 to 4 months minimum for the MRI to look better. If you do the MRI at 1 month, it will almost surely look worse. And unnecessarily patients land up with either panic or surgery. So if you do an MRI at 1 month, it will almost surely look worse. At 2 months also, it may look worse. I think 4 months, Dr. Bhavin, you're nodding your head. So 4 months is the safest, even 6. So even 4 months is not that good. And therefore, early scans may show worsening, and don't do early MRIs because it will just create a panic for everybody. You can wait. Yes, so I'm also not saying don't do MRIs at all. So if at 2 months patients is getting worse neurology, worse pain, etc., then do an MRI. And if that is showing serious worsening, you do have a problem. But if the patient is getting better and you're doing an MRI at 2 months which is looking worse, don't say that I need to operate this patient. What about surgery? Basically, we do debridement, we do decompression and reconstruction. And the decompression and reconstruction goes hand in hand. Just a few things for the surgeons. Surgery, TB has got a little zone concept where the anterior zone is the zone of disease and we need to decompress, debride and reconstruct that. And the posterior zone is usually intact, not always. And this we use for your instrumentation, etc. So we need to approach it adequately, do an effective decompression and reconstruct the defect. So reconstructing the defect is also very, very important. And therefore we need to attack the anterior column where we do all of. So I think I don't want to go in great detail at this point. But the point is we do an anterior based decompression and reconstruction for them, which in the past we used to do in the thoracic spine anteriorly. And we then added, so I'm going historically, we used to only debride, which failed, which was the ALD. They used to get worse deformities. Then we started bone grafting, which got slightly better. But then there were problems because of graft slippage, etc. So then we added instrumentation because we realized that there is no problem in instrumenting TB. And that increased the safety of the surgery. You got early mobilization and you could also correct deformities. So, something like this, which you debride, stabilize and bone graft, heals up to do better. Something like this with AKT not working well for whatever reason, worse deformity, cord compression, etc. You debride and you treat it and this patient then gets better. So we don't have to do anterior approach for everybody anymore because we have this transpedicular approach now where the principle of the surgery is the same. We just do a posterior incision and then go in from the side, but you have to fix these patients. You can't not fix them because you're going through healthy elements. You are removing facets and pedicles which are otherwise healthy and can support the spine to do your debridement, and therefore you need to fix. And if this was the anterior approach, then this is the transpedicular approach where you remove this area, and then you are able to look to the front of the spine. And so it's technically challenging, but now everybody is doing it, and you can get these same sort of x-rays without opening the chest. Of course, in the cervical spine, you do it bang anteriorly. And there are some cases like this which have only a posterior epidural abscess, the so-called spinal tumor syndrome, where you have to anyway not go transpedicular but do midline. Bhavin, only one question. You can't biopsy this, right? No, this is inside the canal.
No, it's not. You've got pedicle involvement and lamellar involvement.
Okay, maybe not this patient, but if you have only an epidural abscess, can you biopsy it?
In the lumbar region.
Okay. So he's a guy who never says no, but I think most people will say that epidural abscesses they can't biopsy. We also do minimally invasive surgery now. We can do all of these fancy things, put in screws through small incisions, do debridements and reconstructions through smaller incisions and smaller scars. But this is just fancy stuff to impress all of y'all. Most spine surgeons are able to do this. And sometimes we need to do surgery for residual abscesses. So something like this with a lot of AKT still has residual abscesses which are causing mass effect. And again, we can drain them in various ways, but we can even drain them by a laparoscopy or retroperitoneoscopy with very, very small scars. And these patients really go home the very next day. Deformity is another indication. If there is progressive deformity, dorsolumbar junction deformity in young children, and young patients, or circumferential destruction, or multiple, like 3-4 vertebrae gone, then it may require a stabilization as well. Childhood TB is an entire different chapter which you please read on your own. And these patients require stabilization as well. So, you do the standard fixation, correction of deformity. I mean, I don't want to add the technical thing here. The main thing is the principle is that you do a posterior correction and an anterior reconstruction. And this is like deformity, and instrumentation is absolutely mandatory for these patients, and fusion is the aim. So in short, now to just come towards the end, one must understand what aspects of spinal function are affected by the disease. So TB spines are different, all are not the same. And we must know that some of these are temporary. So for instance, instability can be temporary because when the AKT acts and the bone fuses, it becomes stable. Deformity cannot be temporary. If somebody is going to a progressive deformity, the best that can happen is he stays at that deformity, but it's not going to improve. Neurology can still be temporary. If you've got a partial deficit, when the abscess dries up, that can recover. So you need to know which is temporary and treatable by medical treatment and which requires actual physical treatment, which is a surgery. And you need to know which can be given conservative care. Now, conservative care may be efficacious, but the speed may be slow. That's what I'm saying. When a patient has grade 2-3 power, we are not saying that AKT will not dry up the abscess, but it's going to take longer. That patient should be given the benefit of surgery. And surgery is needed to take care of that which AKT cannot achieve within time. One second. I think my last slide is coming up. Final words. Yes. So medical therapy is still the mainstay of managing TB spine. You need to know the indications to intervene, and decision making is based more on clinical grounds than the MRI. So don't only depend on the MRI for your treatment. Once you decide to operate, then of course you need to do the best of decompression and best of reconstruction to get your neurological recovery. And in the long run also, you need a stable spine for you to be to get a good function, because I think patients want that. They don't really want to be left with a sort of deficit. Thank you.